So what I will try to do now for the next few minutes, and actually the previous case was a very good example on pocket infection, and there has been some recent data on how to manage these patients. It's a very important clinical problem, not so frequent, but when it happens, it's important to have proper strategy. And also I will give you a little bit of information on a European registry, which is called the ELECTRA. It's a registry specifically on pacemaker lead extraction, and I will give you an update that was actually presented in London just a few weeks ago. This is a review paper that was published very recently and that I recommend because it summarizes a lot of aspects related with this condition. Here we have some data regarding the incidence of cardiac implantable electronic device infection. These infection rates vary according with the definition and the follow-up duration of these patients in the different trials or in the different studies that were done over the last few years. The estimated incidence is about 1.8 to 2 per 1,000 device years, and it's higher within the first 12 months of implantation, which is easily explainable. The infection risk goes up from pacemaker implant, which is the lowest, 0.5 to 1% within the first 6 to 12 months, and then a little bit more for ICDs and even more for CRT recipients, which can be about 9.5% over 2 years. And among these, it's highest when there is a CRT implantation of a CRTD. The infection risk is higher for devices who are implanted at thoracotomy and may be 2 to 4 times greater after device replacement and upgrades compared with primary implants, which also is easily understood because basically we are touching territory that has been already explored. If we think about the pathogenesis of this condition, basically there is a breach of the skin barrier which introduces bacteria into the pocket. These may colonize and not always cause clinical relevant infection. However, the pathogenesis is associated with the formation of this sort of a biofilm on the device surfaces, and it creates what is called a self-produced polymeric matrix, which is adherent to an inert or living surface. And again, this makes it difficult, for instance, for the penetration of antibiotics in this area. So the bacteria, they are protected by host defenses and also by some antimicrobial agents, and therefore the option or the alternative for the treatment of this condition is actually the entire device removal to treat the infection. Most infections are caused by bacteria, which many of these bacteria, they are actually part of the normal skin flora of the patient. There are gram-positive species which are most frequent, usually the Staphylococcus species, less commonly the gram-negative and fungi and others, and cultures can actually be negative in about 15% of the patients. Here we have some data which shows, again, staph being about 42% of the microbiology that was found in these patients. Other sources of infection could be Staphylococcus aureus with about 25%, and then you have a whole array of different agents that can be responsible for this condition. In terms of clinical presentation, as we have seen in the clinical case, pocket infection is the most common presentation. However, this should not be assumed as always as a local infection, because many times there are tracts along the leads that, and this can be related with the secondary bloodstream infection and even endocarditis, which can then be shown or been visualized by the pocket infection, which may actually be secondary and not necessarily primary all the time. Less commonly, the mechanism of bloodstream infection it can be actually hematogenous spread of the bacteria from any other sort of infection in the patient, and then with the secondary involvement of the intravascular parts, the leads of the implanted devices. So it's important, again, to have a complete assessment of the patient so we can understand exactly what is the reason or the cause for the infection. This is a typical example of a case of a patient with, as we've seen in this case, which can present with this pocket infection and can go up to the extrusion of the material as shown in the bottom right of the image. And then, as we've seen also in the case presented, the use of imaging, and particularly the use of echo, can be quite useful. This is an example of with transesophageal echo that shows this mass that is adhered to the lid, and then the surgical debridement that showed the evidence of this mass along the lid of this implantable device. And again here, evidence of large vegetations. So these are the cases which can be easily visualized, and it's clear the diagnosis, and also it's clear the strategy to manage these patients. Very recently, and particularly in more difficult cases to diagnose, it's been, and this is a very recent paper that showed or demonstrated the potential use of more refined imaging like PET to trying to identify and diagnose device-generated pocket infection. These are two examples. This is an example of a patient who had an increased upload of FDG PET and at the site of, at the pocket site. And this is an example of a patient who also had pain at the implantation site and with negative PET. And what they went to look at was that the amount of upload was actually related with the chances of the patient developing infection. So the group 1 were the patients who did not have a clear infection, group 2 the patients with infection that were extracted, and you can see that there was a much higher on the right side, although with a little bit of overlap. And then when they look at the extracted versus which were the infected cases, there was a clear evidence of an increased uptake of FDG by using PET, which again may be related in a way with an increased diagnostic accuracy for the early diagnosis of this pocket infection. So a potential use, it's a very sophisticated technique, not available everywhere, but particularly for early diagnosis, which is very important because the earlier you diagnose and the earlier you start medication in these patients, also the better the likelihood of having a better outcome and a better result. There have been published some guidelines, and this is guidelines coming from the American Heart Association, published a few years ago on the management of these patients, basically, and this is a busy slide, but it basically, you can here divide in two groups of patients, patients with positive and negative blood cultures, and if the patient has positive blood cultures, do a transesophageal echo, which will give you immediately if there is vegetation, no vegetation, and then according with this, it will guide you through particularly how long you should be treating these patients. And at the end, what is probably the most common implication when you have an infection like this is the need to implant, to extract and to implant a new device. And here again, you have recommendation on the timing that should be used between the infection, the extraction of the lead, and then the reimplantation. And it can go from 2 weeks from 2-3 days if there is no evidence of infection anymore, to prolonged 2 weeks if there is evidence of valve vegetation, for instance, in a patient who had positive blood culture. So this can actually lead you in a way on to select better the timing for the reimplantation, because many of these patients need reimplantation of their devices. In the previous case, probably this patient, I would probably have a more conservative approach, but at the end we see many of these cases and many of these patients who do have this sort of complications, and you feel a little bit, I would say, rethink the whole strategy, particularly in a patient who had no shocks, and you wonder about the indication. But this patient that you showed, he had non-compaction, he had evidence previously of non-sustained VT, so I would guess that most of us will put an ICD in this patient, and then it's just unfortunate that, in a way, was good because the patient had no shocks, but it's unfortunate the way it ended up with the infection and with the outcome that you showed. But let me just update you a little bit on this European registry, the ELECTRA, European Lytic EORP, the Euro Observational Research Program, which is, by the way, chaired by Professor Ferrari. And can I have, good. The background was, of course, that transvenous lead extraction is the gold standard in the treatment of these infective complications of implantable devices. And it's often required in the management also of lead malfunction, so it's not only for infection, but also in some cases of lead malfunction. In Europe, there is an increasing number of centers that have started to perform these procedures, and these procedures are partially unexplored across European countries in regard to what are the appropriate indications, the techniques that are used, the success rates, the safety, and the follow-up. And that was the reason why this ELECTRA registry was started a few years ago. These results that were, as I mentioned, presented just a few weeks ago included 3,500 patients, actually a little even over, coming from 19 countries, 72 centers, who enrolled patients for the registry. These are the general results in terms of patient characteristics. For instance, about 40% of the patients had chronic heart failure, and you can see also the age distribution of these patients. You can see here that about 53% of the patients had pacemakers as the device, and about 47% defibrillator, and only a very small percentage they had no generator. You can see here the indications, and again, a little bit over 50% are due to infective indications, and then the remaining are due to mostly to non-elective indications, and then just a few with other indications. You can see here a very important conclusion from this registry, which actually applies to other interventions. There is a correlation between the outcome and particularly the development of complications and the volume of the centers. So the centers who had low volume, they had a higher rate of major complications compared with the high volume centers, which again, it's very important when you deal with such complex procedures. And also, very importantly, the mortality rate was double in the low volume centers compared with the high volume centers, which again, it's a clear indication that probably these procedures should be concentrated on the higher volume centers to get better results. These are just some of the major complications related with the procedure. Here we can see the follow-up of 12 months, and you have on light green how many patients have been followed up, which is quite good, and how many have been additionally enrolled over the years. And here we have close to 3,000 patients who have been analyzed in this registry. Very important when you look at the follow-up of 12 months, and you can see a clear difference in terms of mortality between the patients who had lead extraction due to infection. It's almost 3 times more, it's actually about 3 times more than the patients who had extracted leads due to a non-infectious reason like malfunction, which again shows that the presence of infection is a risk factor for a higher complication rate and a higher mortality. Here we have the general results. So infective complications in about 3.2% of the patients, about the same local and systemic, and about 5% of non-infective complications. These were the general conclusions of this registry. It's really the first large prospective registry on transvenous lead extraction, which was conducted in the ESC countries. Infective and non-infective indications are almost equally considered in clinical practice, about 53% in infections and the remaining non-infective indications. The efficiency of this transvenous lead extraction is confirmed by a high radiological success rate and relatively low complication rate, but the outcomes are much better in higher volume centers. At 1-year follow-up, the mortality rate was lower than previously reported and statistically higher in patients who had indication infective endocarditis to remove the lead. Of course, there is a more accurate analysis of all collected data, will provide more details, and will make possible a better knowledge to improve the clinical outcomes in these complications. And with this, I will finish, and again, thank you very much for your attention.